ER that's actually attached to a hospital, you can have that same service here at Johns Island Freestanding Emergency Department. It's in a racetrack format, so the treatment rooms are all on the outside, imaging is in the back, reception's in the front, and then all of the core services in the center are really like the supplies, the nurse station, those types of things to create that ability for us to manage our patients at the Johns Island Freestanding Emergency Department. This is a kind of a site plan, so Zelasco Drive will be improving that road, and that will be actually the way that individuals will come into the facility. So I know, driving on Maybank, we will actually not have a curb cut from entrance exit curb cut from Maybank. You'll come in on Zelasco into, okay, so you'll come in here and be able to enter the facility. The ability for ambulance traffic to rotate around, but the building will actually face Maybank Highway. Velasco's right here. Really familiar with?
Show them where Kiss Cafe is, they'll figure it out.
Right, it's where the red line goes up. Yeah, Kiss Cafe is right there.
Thank you for that reference.
And on the other side is the event. This way.
We live on Velasco.
There you go. So it's an exciting day for us. Obviously, we were looking forward to the opportunity to come and talk about the project and really where we are in the project. Today, we received kind of final approval in terms of our stormwater plan from Johns Island. We got that today. And so that will allow us to submit our final building permit, which we expect to hear back in a week to 2 weeks. And then we'll be scheduling the groundbreaking probably for the 2nd to 3rd week in September. So really right around the corner. The construction for this, site work and the building and the finishing out of the emergency department will take about 11 months. So really about a year from right now, from today, we'll be doing the ribbon cutting and the opening of the freestanding emergency department. So that's really kind of our timeline based on, we have been engaged in the process of going through permitting since June of 2024. So that process of really getting the design approved, all of the permits that we need to go forward with construction. And so we received the final stormwater today. So thank you for that. Right.
And that's usually the last step.
Right.
Anything going through TRC is the stormwater. It's got to go through them to be approved. It's going to be the water on the site.
So we got a phone call around 4 o'clock this afternoon that said we were good to go. And so that's really kind of where we are from a plan standpoint and from a building standpoint. Likely we'll be communicating with you all about a groundbreaking ceremony mid-September.
How will y'all handle stormwater? On-site ponds, or how is that going to be handled?
Yeah, a lot of it was the pitch, from what I understand from working with our local architects, the pitch of the runoff. And I believe we finished with 2 retention ponds. It's either 1 large or 2 more medium-sized retention ponds. But the issue that was holding things up was more of a pitch within the runoff into the retention ponds.
Great question. Yes.
Can you go back to the screen, the street and the,
The site plan?
yes. So that, where the Kiss Cafe is on the other side of the street,
Is that?
yes, just raise a hand, who in here has eaten at the Kiss Cafe or Cabanas? So when you come out of Kiss Cafe, I'm just using that as a reference, when you try to take a left, so towards James Island, it's super dangerous. So when y'all develop this, and we're all grateful that this is coming, I'm sure, but when y'all develop this, and when it is developed, it's gonna make it more challenging for people to pull out of that center that's already been developed across the street, and vice versa, where y'all are gonna start your footprint here and keep developing. So just an idea for, the city council and to start planning for how to slow cars down and potentially let people walk across the street
Sure.
to go eat lunch or whatever. So just something to keep in your back pocket.
And I think as they go forward, with this emergency room is probably not gonna be that big of a deal. But as they get into the construction and the planning for the hospital, now the city's gonna be more involved in figuring out how do we get people in and out of the site overall, whether it lines up with the road that's coming out of where Kiss Cafe is, or what they do, maybe they'll have a traffic signal there or a roundabout, don't know, but once it goes to the hospital level, I think we'll see a whole bunch of different stuff as far as traffic.
So what we will engage in is obviously the development initially of the freestanding emergency department. We're also talking with providers, with physicians, about expanding medical offices here on Johns Island. Associated, we've got some actually leases that we have in the area, and we're thinking about how we expand primary care coverage, OBGYN coverage, pediatrics coverage, cardiology coverage in the area. Those are really opportunities for Johns Island in terms of physician coverage. As we continue to develop this site, what I've experienced with our company in other markets, as we start from a freestanding emergency department, we add medical offices, we'll look at imaging center, maybe a freestanding ambulatory surgery center, and then that's all kind of knit together to create the hospital. So you get the ER, the radiology department, the OR, all that then comes together with inpatient beds. And we'll use the research from the freestanding emergency department, which will help us understand how large of an ICU, an intensive care unit, will we need on this site based on the utilization of the emergency department. Or, based on the feedback we're getting from the OBGYN, how large of a maternity ward from an LDR and a nursery will we need here on the site? How large is the cardiovascular program that's needed in the community? That'll tell us how many telemetry beds. Those are specialized beds for heart monitoring in a hospital. And so that will instruct us in terms of how we finish out the hospital based on the size of the different units initially for Johns Island.
How many beds were you approved for with the CON?
40 beds.
That's the initial, you need to go from there and you submit.
So the interesting thing about the Certificate of Need program in South Carolina is we applied when it was fully operational and robust. The state legislature has sunset the Certificate of Need program. And so hospitals and health systems are no longer required after 2027 to go through the CON process to add inpatient hospital beds. So we really, unless they resurrect the CON process, we won't have to go through that to expand the Johns Island Hospital.
But you got the initial 40.
We do. And, based on construction timelines, we don't have to adhere to even that 40 bed when we open the Johns Island Hospital, because given this is opening in 2026, it'll be past 2027 when we open the full hospital. And so we'll be able to size and scale that based on really, what we're learning from the community about the health needs here. Yeah, absolutely.
Not to ask a dirty word, do you have a helipad in the plan?
We will not have a helipad in this phase of the project. So individuals who require inpatient admission who come to the freestanding emergency department will be transported via ambulance, ground ambulance to that location. We do have an internal kind of ground ambulance system within the Tri-Health system that will be able to transport them. And we'll likely leave an ambulance here.
40-bed hospital, how How many beds is the Trident at the North Charleston now?
So we are 312 beds at the Trident campus. We're 175 beds at the Somerville campus. And then our Live Oak is, we just got CON expansion for 84 beds at that facility.
And that's where Monk's going?
That is off of 26 and 78. So it's fairly close to Triton in terms of its location. You know, what we have kind of seen is kind of the initial foray is that 40 to 50 bed kind of hospital launch is pretty typical. That's actually what Roper did in Berkeley County when they opened their facility. They opened it as a 48 or 50 bed facility.
So you know about how many jobs total, or how many positions total for the ER?
Yes, so, we'll, do the count in my head. There'll be about, 80 staff members, 80 staff members. Because obviously this is a 24/7 operation, so we'll need physicians around the clock. We'll need reception staff around the clock. We'll need security guards around the clock. We'll have a core team of nurses that will work around the clock, grad techs around the clock. So 80 staff members in this location. Yes?
So this is an emergency facility, right? So, I guess I have kind of a two-part question. Please, just give us 4 or 5 examples of the kinds of things that they, serious things that they would be equipped to handle. And then, like say, okay, this person is stabilized, then, but this is an emergency hospital, so they're not gonna spend their 2 weeks of recovery here. Where do they go and how
Yeah,
do
so
they
that's
get there?
really the patient preference. So depending on what is the condition that we need to treat for the patient, obviously within the Trident Health System, we have hospital beds that we provide services really for every patient need, with the exception of solid organ transplant. That is something that is really only done at MUSC. So if someone came in and they needed a liver transplant, that is not something we can do in the Trident Health System. You can't do that within the Roper system. You can't do that at Novant either. That's only can be done at MUSC. But if someone came in cardiac arrest and they needed an emergent STEMI or a CABG, we would be able to provide that service at Trident for that. We will, if a young woman came in and she was imminent to deliver a baby, we could deliver the baby here. We would then, after delivering the baby here, we would transport that mom and baby to our Somerville Medical Center, where we have a level 3 NICU, where we have all of those services at that location. You asked about what's appropriate here. Really, any health condition that would require emergency services.
Gunshot wounds.
Yeah, absolutely. Gunshot,
Hopefully not.
stabbing, somebody who has,
Vehicle accident.
yes, somebody who has a chronic disease that's kind of flared up, like if you are a diabetic and your insulin's really out of whack and things are going, you need to come to the ER and we need to triage that, we need to get you stabilized, so you can heal. So all of those conditions can be cared for at this facility.
And then the norm would be the person would not be there more than 24, 48 hours.
Yeah, I mean, it's our goal actually, if someone comes to the emergency department and they can be discharged, they can be treated and discharged, we really want to do that in less than 3 hours.
So, okay.
We want them to come in, we want to assess their condition, we want to run labs on them, we want to get imaging, we want the physician to figure out what is going wrong, and if they can be discharged, like follow up with their physician, or if they need fluids and can be discharged, we really do want that on average to be less than 3 hours. For our admissions, patients who come to the emergency department and maybe their heart rhythm is in what we call VTAC, or they're not in normal sinus rhythm, so their heartbeat is not doing this, maybe doing this, or if their rhythm isn't what we would expect and they need telemetry monitoring, we would want to transfer that patient to a hospital that has the services that can provide that ongoing monitoring and perhaps do a cardiac cath procedure or an electrophysiology procedure on that patient to get their heart back into what's called normal sinus rhythm. I feel like I got some nurses in the room, so I want to make sure I'm saying the right things. But we want to make sure that we do that well in that environment. That's not an ER environment for care. Really, the purpose of the emergency department is to do that initial assessment and stabilize. If it can be treated within that shorter time frame, we will treat and then discharge. If it can't be treated in that time frame, typically those patients will go to an admission status, and then we'll care for them in a full-service hospital. And so when we ultimately build the full-service hospital here on Johns Island, there will still be patients who will need to be transferred out for different types of services. But what we would consider is there would be some ICU level of care, likely some cardiac monitoring care, and then what we consider medical surgical care here, in addition to obstetrical services. That's likely. Again, we do want to kind of understand what Johns Island needs based on the experience in the emergency department. Yes?
Is James Allen facility as well equipped as this one, or is it just a dock in the box type thing?
It's exactly like this.
Okay.
So the James Island freestanding emergency department that we opened in 2023, when we announced this, the James Island facility is actually very similarly laid out to this structure. There are 12 rooms there. This is an 11. So it's, obviously the work on the site and how we scale that. But that facility is similarly structured, and it's the exact same kind of services. So same staffing model, same capabilities that this facility will have.
Another question. If EMS picks up a patient, and the patient's unconscious or whatever, and I think MUSC is building some facility here on the island too, who makes the determination about whether they stop at y'all's place or
It's a great question.
MUSC is going downtown to Roper or MUSC?
So the law or regulation is that EMS should take the patient to the closest facility for stabilization unless there is a particular preference by the patient for a different location, or if there's a unique service that is needed for that particular patient. But it should be the closest facility for immediate assessment and stabilization.
Is that closest by mileage or minutes?
So I would actually refer to an EMS professional in terms of how they do that assessment. But yes, they would take it to the closest facility to wherever they're picking the patient up from. So if they're picking the patient up from their home, or they're picking their patient up from a place of business, or a motor vehicle accident along the side of the road, it would be the closest facility that they can get that patient in front of an ER physician who can assess that patient and determine what is their level of care and their need, and then figuring out how to stabilize that patient and get them to where they can receive longer-term treatment. Yes?
Do they take into account the size of this emergency triage thing, and maybe that there's people in there and there's somebody needing some emergency service, and say, hey, it might be smarter to go to a bigger place that has an open spot?
They're gonna go to the closest place because that the way that works from a care perspective is, your physician is gonna be initially triaging patients, and then that physician is going to be directing the nursing staff for their continuing care. And so that physician is freed up to connect with you, and then connect with you, and then connect with you. The only time that would not be the case is if they are running a active code situation, and the physician would need to be with that particular patient, running the code, while we're, essentially bringing somebody back to life. So EMS would continue to go to the nearest facility because the physician is going to lay eyes on that patient, is going to do an initial assessment of that patient and determine what they need.
But you do have diversion protocol,
We do.
so you might need to understand what diversion is.
So if a facility, and I will say this, in my tenure, none of the freestanding EDs have gone diversion based on volume or staffing. And this facility will have generator power as well, but if a facility lost access to electricity, that would be a reason to go on diversion because they wouldn't be able to provide like imaging services while they didn't have access to electricity. Or I've heard of facilities going on diversion because the flow of water is either interrupted or contaminated to the facility, and that has to be addressed before we can continue to care for patients. But in my tenure, we have not gone on diversion in our freestanding emergency departments. But if we were to do that, we would notify all of EMS that we do not have the ability to receive ambulance traffic. But what you all have to understand is we never go on diversion for walk-ins. So our doors are always open to individuals who would be driving themselves or a family member driving you to the emergency department. We would never turn a patient away. We would figure out how to provide care for that patient who came to us via their own personal vehicle. Yes?
Two questions. One, how many docs are going to be staffing? Is it just trauma doc or other?
So in this facility, there'll be a physician who is board certified in emergency medicine. So Trident Medical Center is a trauma center, and we have trauma physicians as well as board certified ER physicians. We will not have a trauma physician here at this facility because it's not going to be a trauma ER.
And just one doc or multiple?
So typically, we have different shifts of providers, and so the other thing that we will learn from the community is when is there our kind of peak bolus of patients, right? When do patients typically come to this facility? And so it may be that we have a single physician from 2 a.m. to 6 a.m. and then another provider comes in and we have multiple physicians for a period of time and then we only have one physician there and then it really depends on how we get the flow. We have currently 4 freestanding emergency departments at this currently. So we have one in Monk's Corner, we have one in Nexton, we call it Bright Park, we have one Center Point, which is the intersection of 26 and 526, and we have one on James Island. We are currently in the process of building 3 more, one of them on Johns Island, one of them in Mount Pleasant, and one of them in Cane Bay, in the North Somerville area. So each of those have a little bit of a different staffing model for their physicians based on patient flow. So we assess that and then we schedule physicians really based on the typical volume that's coming through the emergency departments. And there tends to be a predictability to that based on the community.
Second question, hurricane plans. You gonna stay open, you gonna evacuate?
We would stay open.
Okay, you got power, you got staff.
Did you say you don't have a trauma doctor here because this is not a trauma?
It is not a trauma center. So there are only 2 trauma centers in Charleston, NUSC and Trident. So those are facilities that if there is a trauma, those patients would go to one of those two hospitals. So, you'd ask the question about where EMS would take a patient. They always take a patient to the nearest facility. If you are a trauma patient, then you would bypass to go to a trauma center, and EMS would determine your trauma level and take you to the trauma center. So there will not be a trauma surgeon here. The trauma surgeons are based at MUSC and Trident Medical Center in the Charleston metropolitan area. Those are the two facilities that have that capability. And to be a trauma center, we are required by regulation to have physicians with certain skills in the hospital 24/7, 365, or available to come to the hospital within 30 minutes, 24/7, 365. So at Trident Medical Center, we have both ER physicians and trauma surgeons in the hospital 24/7. We also have cardiologists that have to respond within 30 minutes. We have neurosurgeons that have to respond within 30 minutes. Orthopedic surgeons that have to respond within 30 minutes. OBGYNs that have to be able to be in within certain. So there are regulatory requirements that define what a trauma center is. No freestanding emergency department is a trauma center. Yes?
Once this is built, how much data collection and assessment are you gonna have to do before you decide to build another parcel?
I would imagine that, this facility will likely open in August of 2026. Pretty quickly in 2027, we'll really understand and know kind of what are the next phases for construction on this site. 6 months to a year of data is, you want to be able to go through certain seasons to understand what that looks like, because there is some seasonality there. And so we'll want to be able to hit a couple of seasons and understand what that looks like. And that will help us plan for the next phase.
Based on the population here and the population type, what do you think that y'all will be building most likely?
I've heard from conversations with people in the community that there's a need for pediatric access here on Johns Island. For, like I mentioned, cardiology. We work very closely with Palmetto Primary Care Physicians, PPCP, and so the question is there an opportunity to expand their scale and scope here from a primary care perspective? So those are all things that we already know that we need to figure out how we provide those services to Johns Island. But the information from the ER will also be very instructive in terms of, if we have, say for example, we have individuals who are coming in and it's a pain control issue and they're in, intractable pain, and that ends up being because of orthopedic issues, that'll help us kind of understand if that's a specialty that we need to focus on here on Johns Island. If we have, individuals who are having challenges with managing their diabetes, do we need to work with nephrology to see if that's a service we need to provide? Yes?
Can you go back to your drawing that shows the building with the landscaping and architecture?
This one or?
The one color, very beginning you showed it. Right, that one. So is that an accurate depiction of all those trees will still be around that building?
So, this is an artist's rendering. This is one of the things, I came to Charleston from San Antonio, Texas. That was, I ran hospitals in that location before I'm transferring within our company to Charleston. And we had what we called live oaks in San Antonio, Texas. I gave you a little nod. I learned very quickly that the heritage oaks, right? Those are very important trees. Live oaks were very important in San Antonio, Texas. It's the same tree, just to let you know.
Right.
If You did
It
say-
looks like there's a lot of trees still back there, and actually, I think because we've already, roads all back there, houses all back there.
Yes, so, this picture is an artist's rendering, but we will work very closely with, council about how we clear the space, we want to do that thoughtfully. I want,
Ponds and.
I want the aesthetic to be very inviting and lovely, and so we want to make sure that we're thoughtful about how we approach that.
Well, Mary, some of that property behind there will be that park that the city's gonna build on the property.
That's the next land over.
Yeah,
That's
that's
parcel
parcel,
over.
yeah, that's not behind there.
Yeah, it's right, if you're looking at that, that would be right down where those trees are.
On the other side of the trees.
The pond, that, you know, where the big pond is in Lewis and
I just asked if they'll still have any trees around it, because most everything, they have a picture with lots of trees, they're not gonna damage the environment around it, then you go back and it's like, oh, wow, this is the parking lot now.
Just so you know, that's one of our big things here, is the trees. How we cut down, when you do your site plan and you mark and you do your tree survey, mark all the trees and what they are and have them evaluated, we'll wanna see that.
Absolutely, I trust that. You had a question about.
Yes, I had a question about the building timelines and how they will impact local employment, and if y'all's recruitment process will prioritize Johns Island residents.
So, again, our timeline got stormwater approval today, 4 o'clock. We do expect with the building permit to announce in the next week, when our groundbreaking ceremony is gonna be in mid-September, and then it's an our general contractor is telling us it's an 11-month construction cycle, to do all the site work, and then to plant the building, build the building, and then to finish out the building. So thinking about kind of next, August, in terms of a ribbon cutting and an opening. From a recruitment standpoint, absolutely. We will want to recruit individuals from Johns Island to work at this facility. That is true of our other freestanding EDs. We have core staff that are on James Island, and we have core staff that are in the Moncks Corner area. So yes, that will be our plan. If someone wants to work here, who lives in another part of the city, we'll explain about traffic and the expectation that they are actually here when their shift does start. But we wouldn't turn someone away who doesn't live on Johns Island. But absolutely, I mean, this is a service that we want to provide in collaboration with the community. We want this to meet the community's need. We want it to serve the residents of Johns Island, and so there's really no better way of doing that. We talk about at Trident Health and within HCA Healthcare, we are a family taking care of our families, because for the most part, a lot of our employees, and this wouldn't be a surprise, I mean, their parents, their children, their other family and friends come to the hospital where they work to get care. So we take care of our own as well, and so we would expect to do that in Johns Island. Yes.
When you're talking about building on the extra facilities as you gather all the information and everything, are you looking at building it on that piece of property?
Yes.
And then would they be freestanding buildings on that piece of property, or are they all gonna connect somehow and flow, or?
So, in my experience, I've seen it kind of two ways. I've seen the site go from a freestanding emergency department, and like I was mentioning, kind of adding an ambulatory surgery center, and then that's connected when we build the inpatient beds, and then the inpatient beds go on kind of a second floor or kind of go up, and then this becomes the emergency department, and then the ambulatory surgery center becomes the ORs, and you kind of you construct it that way. Obviously, there's already imaging in here. You've already got a CT scanner, ultrasound, X-ray already exists, so that can become radiology. I've also seen it where we have a freestanding emergency department, and then we have a construction for a freestanding hospital, 50-bed hospital. And then this is converted after that new hospital is built to some other purpose. Maybe this becomes kind of an outpatient, like a wound care center, for example. You could look at that, or an outpatient infusion facility. So I've seen it kind of different ways within the company and the different markets that I work in.
So when you go put together all your numbers and you build out these different facilities that you think that Johns Island needs and everything, do y'all look at the amount of traffic it's gonna help keep off the two bridges and all that stuff?
Yeah, we also look at housing stock, how much construction is going on, like how many apartment complexes and townhouses, and what is the development plan over the next 5 years that community leadership has approved from a permitting standpoint. How many rooftops are going to be in the area? How many lives will be, how many residents will be in a 10-mile radius of this facility? We'll look at all of that information to help understand the size of what we will be building next.
Is it equipped with its own ambulance or two?
So we will have, we'll have an ambulance that will kind of sit here to be able to transport patients, but we're not EMS, so our ambulance would not be going out into the community to pick up a patient and then bring it to the freestanding emergency department. We would rely on the community infrastructure from an EMS perspective to do that, but we would transport that patient if needed to another facility.
Okay, Ms. Mayor, what do you have in place, Johns Island, as much as there's a lot of very wealthy people with K1C work, there's a lot of people who work in the service industry which have no insurance, very, very underpaid. Try to offer anything for services for those?
So in an emergency situation, we certainly will, when a patient comes to the emergency department, first thing we will do is we will stabilize that patient. That's actually required by the law. We are required to reset and stabilize any patient who comes into the emergency department. After that is done, we have a conversation about insurance. We will then take insurance information. But if a patient does not have insurance, that does not change the care they receive in the emergency department. They will continue to have their labs full, they will still have imaging, they will receive medications, even if they don't have an ability to pay. We have financial counselors. We work with individuals if they have some ability to pay. We have sliding scale fee schedules, but if an individual is uninsured and has no ability to pay, they can still come to the emergency department and need care. Absolutely.
Okay, gentleman in the back?
Sorry.
The retention ponds that you're talking about putting out there, where does the water go to when it overflows? When we get hurricanes, it's not going to hold all that water.
I'm going to be honest, I don't know the answer to that question, but we can certainly talk with our contractors who develop those plans, who got those plans approved. I just don't have that technical knowledge to answer that question.
So if stormwater has approved from the city, they've already looked at all of that. What's the capacity, where the water flows, where we're draining from the site? Has to go through all of that through the city, before they would even approve it.
We got it approved today, so I don't have that technical knowledge, but I'm confident that the plan that we put forward, obviously since we approved it, was deemed appropriate for the site and the weather patterns.
Just add,
One second.
just add that to what Peter said, the city has, my understanding, the strictest stormwater regulations in the state. And they don't just look at the stormwater on the site, they look at how it impacts the stormwater going into the river and all the connections. So that's why stormwater, he keeps mentioning stormwater finally improvements, because they denied them about 4 or 5 times, which happens in every development ever since 2021.
We had a process where we went back and forth to refine.
Yeah, not denied, sorry, strong word.
Okay, okay.
Yeah.
Ms. Brenda, and then we'll get right there.
Will you have a dialysis center at this hospital in the
So
future?
we will have the starting with a dialysis center. But again, if that's something that, if we tend to get a lot of patients here that require emergent dialysis treatment, we would then likely work with local partners like Fresenius or DaVita to see, like, can we open up a center here to create more capacity for patients to have that routine dialysis Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, so they don't have to go to the emergency department for that care.
One right here.
Is there any goal date for when you'll have a hospital open or any type of surgical services running?
So I don't have a specific date at this point, but like I said, give us about 6 to 9 months, and then I think we'll have a much better date for it.
When you go to open a new hospital, will the last will be opened back up to get back there, or will the main entrance be on the King Slash to get to that location?
So that's a very good question. We have not
Work that out?
worked that out yet. I think part of it is really understanding how the community grows and develops, and like we were talking earlier, what type of infrastructure is then put on Maybank based on traffic volume and patterns and how people need to cross, and if there are lights, and those are things that we will be absolutely very interested in, and that will likely both define and refine our plans moving forward. But at this point, I do not have anything that specific for what kind of a longer term plan is.
Charles, Jim?
Who's this lady?
Well, I'm following up on hers. I was amazed to see you close what I thought was a public street. Do you control, do you own both sides of Salatso all the way past the houses that are there?
So Dayton, do you know the answer to that question?
I think we do, that's where the fence goes to, but I don't know, I haven't looked at the property. The fence goes all the way down to
Right.
the,
But I've never seen a street, a public street closed before. That's why I figured you must own all the way to
Zelasco, I think, is how long ago was lived there?
It's a price,
Well, years ago, it was close, that one of the property owners that owned it closed it off,
Okay.
and then another property owner came in and opened it back up, I think they've been
Alright.
squabbling over it before.
So it may not be a full street. Okay.
but
Thank
I would be
you.
surprised if they didn't use both entrances, both on King Slash and Maybank, when they get to the hospital side. I think they'll find that it's best to be able to access both ways, depending on what the traffic is. You may want to go out the back way versus going out Maybank.
Yeah, we'll absolutely work in collaboration with the community on what
We live on,
makes the most
we live
sense.
on Velasco. There's
Got it.
always two houses.
Yeah. Well, thank you very much for allowing us to come and share really our exciting vision for how we can partner with you and provide great care for the citizens of Johns Island. We're excited to get you all out at a groundbreaking ceremony, and so we'll keep that broadly when we have that date, and then continue to give you updates as we go through the construction, and then we'll be excited